to get somebody really strong very fast. And then the special considerations I have with each patient is, of course, I really educate them on the fact that in all likelihood for things like proximal carpectomy, partial wrist fusion, total wrist arthroplasty, they're probably going to have a limited arc of motion compared to their contralateral hand. There's a lifting restriction with the total wrist arthroplasty. And then one special consideration with the total wrist fusion, I have had success in helping people feel more confident in heading into that surgery by doing a test run of like clamshell orthosis for a little while before, so the patient can see how functional it can be in the position that the wrist might be fused in. With all of these patients, I tend to work on proprioception. I'm going to kind of skip through this a little bit faster, but these are just some different proprioceptive kind of activities. Some of them range from something that's completely non-resistive, where you're working on joint position sense, to something that starts approaching resistance with toss and catch. And then this is a gyroscope where there's like a little ball spinning on the inside with centrifugal force that pulls in different directions, so they have to control against it. So that is something that I might use with a higher level patient, a younger patient. And then this is the general force progression. So I'm going to start with maybe some active motion kind of activities, moving into this. These are these little foam cubes. They're very, very light, to work on some light strength, and then working into heavier grip strength. This is blood flow restriction therapy, which is actually really helpful in gaining strength with not even very much motion. So it's like a cheater way to start strengthening. And there's actually research on distal radius fractures with a variety of ages. So just because somebody's older doesn't mean you don't have to be like this young buff person trying to get pumped up to be using blood flow restriction therapy. Can be a very functional way to gain strength while they're just doing active motion kind of things, and then they don't have as much of that atrophy. And then these are just some other examples of things that I like to do to work on wrist strength. A lot of the times I work on stabilizing in one position for the wrist, and then push, pull, and things like that, because that really is like generally how we functionally use our hand, and I find it to be less stressful than typical wrist curls and isotonics, things like that. So that's everything I have.
It's a great talk, Rachel. Thank you so much. Kind of curious, you mentioned a lot of great kind of things that patients could do to adapt to what they do as far as losing range of motion, but still be able to perform ADLs. As kind of your group, do some of the surgeons send patients to you pre-op? That's something I haven't done, but after your talk, something to really think about is prior to a four-corner fusion or PRC where they may lose motion, or prior to a total wrist fusion where they may think, oh my God, it's the end of the world, I can't move my wrist anymore. But there's still a lot they can do. Do you find it helpful to maybe have a patient see a therapist pre-op, just to kind of work on some of those kind of adaptations?
I think especially for somebody who maybe is a little bit more nervous. The other person that I think about is somebody that doesn't have as much social support, that's concerned about being one-handed. I've actually recently did this with somebody with it's completely different. She was a really nervous Nelly. She was getting a total wrist arthroplasty, but her other hand wasn't or not total wrist arthroplasty, CMC arthroplasty. And she was really nervous about her ability to use her other hand because it wasn't great either. So a lot of the times a trial run and them trying things out, and then also learning how to adapt things ahead of time. The other plus that like a pre-op kind of visit can get, and this is, you may not even need a pre-op visit. There's actually a really nice handout on the American Society of Hand Therapists on things to do ahead of time, is like post-op period, like how do you adapt things and do things one-handed? I mean, like not everybody's going to want to just come and see a therapist ahead of time. Like we can definitely do that, but that handout is actually really good. It gives them a lot of tips of like, get your medicine, like containers, like opened ahead of time, like all the different things that they need to think about can make their postoperative period better. And that's like across the board for any diagnosis. So.
Okay, great.
Yep.
I guess Dr. Gupta and Dr. Sud, do you guys do anything special as far as your post-op for PRCs? When do you let them go back to weight bearing on a PRC? And then are there any specific protocols you put patients through for rehab after a PRC?
In the old days, we used to put K-wires into the PRCs. We don't do that anymore. I immobilize them till everything heals up, because all the soft tissues, the capsule and everything has to heal. So that takes time. So I put them in a cast or a nicely contoured wrist brace for about 4 to 6 weeks. And then I'll get them doing range of motion, and I get them, weight bearing by about 3 months.
I tend to be a bit conservative as well, typically. So it'll be some type of, wrist brace, or I usually won't do casts for I'll do my postoperative splint, and then I'll transition them to a brace and things like that, so that they could more easily work on hand range of motion. But probably about 4 weeks, then I really let them kind of go and do everything type of thing. I'm very conservative with my four corner fusions. I don't let them move or come out of cast until I see some union.
Yeah, same. I kind of slow walk them. I don't let them really move it until there's at least some healing, which is about 6 to 8 weeks or so. Do we have a couple more minutes here? Any kind of last thoughts, Rachel, Dr. Sun, Dr. Gupta, for the attendees? We have a great turnout tonight. So
yeah, one of the things about proximal corpectomies is when you do the corpectomies, be very careful that you don't violate the volar capsule and the volar ligaments, because those are going to be very important for the integrity of your joint. And so otherwise you'll get a subluxation, you'll get a volar drift of the capitate, and that's not very nice. So be careful when you're doing that. And as I said, I always start with the lunate first, and that will improve, it'll cut down the time a lot.
So, Dr. Sa, I know you do arthroscopy for a four-corner fusion, and I know you do some PRCs as well. Kind of going back to the volar ligaments, do you find that arthroscopically, it's actually, you can see the ligaments pretty well arthroscopically. Is it safer in your hands? And we talked about vascularity a little bit. Do you find that, at least from your experience, are you seeing faster healing on a arthroscopic four-corner fusion because you're not violating the vascularity as much with the extensive dissection?
I would say I probably don't, my N numbers aren't probably high enough to really know. I think patient pains are probably a little bit better, even though, because you don't have at least the soft tissue dissection, you obviously have the bony pain, and the bony pain's usually what the problem is. I haven't noticed, I think at the end of the day, the principles of the surgery are exactly the same. You need to debride everything, you need to get it to heal, and that just takes time. So I don't think necessarily that maybe will cause it to go greater, but I think definitely it's a bit safer. But safe is a very interesting term, because it's like, it's safe because you see the ligaments, but it's also technically a very demanding procedure. So is it safe as a procedure? It's like, it's
longer. It takes longer.
There's a very steep learning curve to doing it well, I think. And I think, as you do anything surgically, the more you do, the better you get, and things like that. The one thing I will say is maybe the only thing I'm a bit more cognizant of versus when I started for PRCs is like looking, a certain female population sometimes are more ligamentously lax. So caring about ligamentous laxity, particularly for my four corner fusions and PRC, I do think about that a little bit more and test for it, just to try to prevent any complications. But yeah, I think arthroscopic or open, you just have to do it well.
Okay, great. And Rachel, any kind of pearls for the attendees? We're going to kind of finish up the next couple minutes here.
I guess I'm assuming the majority of our attendees are surgeons. I feel like the communication piece is probably the really most important part. Like especially when I'm talking about the postoperative, is knowing like the limits, and like if there was anything out of the ordinary with the reconstruction that makes the soft tissues or the bones where you're expecting that it's going to take a little longer to heal. Because it's always better if the patient has that expectation. Like I said, a lot of times I've worked with surgeons. I 100% know they've told the patients this, and is like as if nothing has ever been communicated to them. But we spend so much more time with them that we can continue that education. So I think that's really important.
Okay, great. And okay, the last question from the Q&A, we'll probably finish up from there. There's a question about, we talked about the volar ligaments and how important they are, the RSC and certain ligamentous laxity. So a patient who's had prior injury to the volar radiocarpal ligaments, either from a volar approach for a scaphoid or some other mechanism, how does that change your approach? Are you leaning towards much more aggressive total wrist fusion, knowing that there's likely chance that PRC or even a four-corner might translocate? An example, Dr. Sush showed that four-corner fusion that probably was okay initially, but certainly developed some translocation due to arthritis. So how does the volar ligaments guide what you do on these cases there?
Well, if you, with the scaphoid volar approaches, um, it depends. If they've taken down the radiuscaphocapitate ligament completely, um, uh, that is not so much of a concern as long as you have all the other ligaments intact. So most of the times, the radiuscaphocapitate ligament would have healed by the time you come to do a proximal row carpectomy. So I don't think it's a contraindication for doing a PRC as such. But again, make sure that when you look at it, you can see the integrity of the ligaments pretty much. If necessary, you can put some sutures in there, tighten up the capsule a little bit. But overall, I think it's not a contraindication in my mind.
I would agree. I don't think it's a contraindication. I think usually by the time you're doing these type of like four corner PRC or something, that's probably scarred and healed. And if it hasn't translocated, probably won't do it, hopefully, when you do your surgery. I just meant in terms of the ligamentous laxity, I do warn my patients about it, that this may not be your only procedure. You may require something else in the future, right? So I do warn that complications can exist from doing a four corner fusion, PRC, or any procedure you do.
Just watch out for the, those types of rheumatoid, the wet rheumatoids who have synovitis, who have ulnar translocation of volar ligamentous laxity. Don't do the PRC in those because you'll get a translocation and volar subluxation of the capitate. So that's, to my mind, the only lookout.
Right. Well, it's 10 after the hour. Thank you very much. I really thank our faculty for outstanding talks, great discussions. I also want to thank our AL team. We have Abby and Chris here with us for helping host this webinar. But thank you very much for joining us and have a good evening, guys. Thank you so much.
Thank you.
You have a good night.
See you
All right.
guys.
Thank
Take
you.
care. All right. Thanks, Jerry.
Thank you.
Thanks, Nina. Thanks.
Yep. Bye-bye.
All right. Bye.
Recording stopped.
All right. I think we're all set, Chris. Thank you so much, Chris and Abby.
Okay. Yeah, thank you.